For years, the most effective medicines we had for type 2 diabetes and obesity all shared one inconvenient feature: you had to inject them. That single fact, the needle, has quietly decided who gets treated and who doesn't. So what happens when the very same class of drug arrives as a once-daily pill? This week, the first large phase 3 trial of an oral GLP-1 drug gives us a real answer, and it forces an honest question. Is convenience enough, or does the size of the effect still win? Welcome to This Week in Diabetes and Endocrinology from Hormone Insight. Every week I take the most important new research in diabetes, endocrinology, and metabolism and ask one simple question. Does this change what we do in clinic on Monday? This week, the headline is Orforglipron, the oral GLP-1 drug in the ATTAIN-2 trial. Then two quick hits. A large network meta-analysis that puts the whole obesity drug field into perspective, and a provocative comparison of weight loss surgery against semaglutide. We'll cover the new 2026 ADA standards of care, which quietly rewired the goal of diabetes treatment. And we'll close with a hormone classic that explains exactly why that shift had to happen. Let's get into it. Let's start with the trial everyone is talking about. Orforglipron is an oral, small molecule GLP-1 receptor agonist. In plain terms, it does what semaglutide and the other incretin drugs do, but it is a tablet you swallow once a day. And unlike the current oral semaglutide tablet, it does not require fasting or careful timing with water. ATTAIN-2, published in the Lancet, asked whether it actually works in the people who need it most, adults who have both obesity and type 2 diabetes. This was a 72-week, phase 3, double-blind, placebo-controlled trial. Good design. It ran across 136 sites in 10 countries and randomized about 1,600 adults, all with type 2 diabetes and a body mass index of 27 or above, to one of three doses of orforglipron: 6, 12, or 36 milligrams, or to placebo. At the start, the average weight was about 101 kilograms, and the average A1C was 8%. The main question was simple: how much weight do you lose by week 72? Here are the numbers. On placebo, people lost 2.5% of their body weight. On orforglipron, the effect was dose-dependent: 5.1% on the lowest dose, 7% on the middle dose, and 9.6% on the top 36 milligram dose. So at the highest dose, that is about 7 percentage points of weight loss over and above placebo, and it was highly statistically significant. And it was not just weight. A1C, blood pressure, and cholesterol all improved as well. On safety, the story is familiar for this class. Mostly mild to moderate gastrointestinal side effects, chiefly nausea during dose escalation, and discontinuations because of side effects ran at about 6 to 10% on the drug versus 4% on placebo. So, now, my comments. The headline here is not the size of the weight loss. 9 to 10% is good, but it is not the roughly 18% we see with high-dose tirzepatide. The headline is the word oral. A pill changes everything about access. Injectable drugs are limited by cost, cold chain storage, supply shortages, and plain needle aversion. A once-daily tablet that delivers most of the benefit and that can be manufactured at scale could reach far more people than any pen ever will. That is the real story. Now the caveats, and there are three. First, this trial compared orforglipron against placebo, not against the injectables, so we cannot claim it is as good as tirzepatide. The cross-trial comparison suggests that, on weight, it probably is not. Second, it was funded by the manufacturer, Eli Lilly, not disqualifying, but worth saying out loud. And third, the gastrointestinal side effects and the discontinuation rate are real, and slow dose escalation will matter in practice. For completeness, there were 10 deaths, balanced across the groups, and judged unrelated to treatment. The bottom line: does this change Monday Clinic? Not yet, because it is not approved or on your formulary yet, but get ready. When an oral GLP-1 lands, the conversation shifts from "can my patient tolerate an injection" to "which patients do I start on a pill first?" For the needle-averse patient with type 2 diabetes and obesity, this is the one to watch. Quick hit number 1, and it is the perfect reality check on that hype. The American College of Physicians published a living systematic review and network meta-analysis in the Annals of Internal Medicine. 69 randomized trials, more than 112,000 participants, comparing essentially every weight loss drug we have. Two findings matter. 1. Across the whole field, semaglutide and tirzepatide produced the greatest weight loss. The injectables still sit at the top. And 2. This is the important one. Semaglutide was the agent that probably reduced death and major cardiovascular events, not just weight. That is the distinction I keep coming back to. Weight loss is a number. Cardiovascular outcomes are the goal. Orforglipron is exciting for access, but as of today, it does not have the hard outcome data that semaglutide does. Verdict: keep your eye on outcomes, not just the scale. Quick hit number 2, a more provocative one. A study in diabetes, obesity, and metabolism used a large real-world database to compare bariatric surgery against semaglutide in people who have both fatty liver disease and type 2 diabetes. The results cut both ways. Surgery was associated with substantially fewer cardiovascular events, a hazard ratio of about 0.5, along with fewer cases of heart failure and less obesity-related cancer. But, and this surprised me, gastric bypass specifically was associated with more major adverse liver outcomes than semaglutide. Now the big caveat: this is observational, database-derived data, wide open to confounding by indication. The patients who are sent for surgery are simply different from the patients who are started on a drug, so do not overread it, but the signal is a useful reminder. Surgery is still a powerful metabolic intervention, and the liver deserves a specific look before you refer. Verdict: hypothesis generating, not practice changing, but worth knowing. Now, Guideline and FDA watch. The big one is the 2026 ADA Standards of Care, and there is a genuine change of philosophy buried in it. For decades, A1C was the scoreboard. Lower the number, win the game. The 2026 standards formally elevate cardiovascular and kidney risk reduction to a co-primary goal, sitting alongside glucose control rather than underneath it. In practice, that means GLP-1 drugs and SGLT2 inhibitors are now positioned as core protective therapy for the heart and the kidneys, irrespective of the A1C. So if your patient with type 2 diabetes and established heart or kidney disease is not on one of these, an A1C that is already at target is no longer a good enough reason to skip it. They also nudged the systolic blood pressure target toward under 120 in appropriate patients, and one more to flag. A UK expert consensus on fatty liver disease in Lancet Gastroenterology and Hepatology now puts resmetirom and semaglutide forward as the first real drug treatments for MASH, with a simple two-step pathway, the FIB-4 score, and a fibroscan, to find the patients who qualify. And that brings me to this week's Hormone Classic, because none of that shift makes sense without it. The UK Prospective Diabetes Study, known as UKPDS, published in the Lancet in 1998. UKPDS was the trial that proved tight glucose control reduces the small vessel complications of diabetes, the eye, kidney, and nerve disease by about a quarter. That is why we chased A1C for 30 years. But here's the subtlety people forget. In UKPDS, glucose control on its own did surprisingly little for heart attacks and large vessel disease, with one exception. Overweight patients given metformin had fewer heart attacks and lived longer. And 10 years later, the follow-up revealed a legacy effect. The benefit of good control early persisted long after the trial had ended. So UKPDS gave us both halves of the modern story. Control glucose early, yes, but glucose control alone will not save the heart. The 2026 standards are simply finishing the sentence that UKPDS started. So, the bottom line: 3 things to carry into clinic this week. 1. An oral GLP-1, Orforglipron, works. About 10% weight loss in people with type 2 diabetes. And its real power is access, not magnitude. 2. The injectables, semaglutide and tirzepatide, still own the outcome data, so do not abandon them for the shiny new pill. And 3. The 2026 ADA standards have made it official. Treat the heart and the kidney, not just the A1C. That is it for this week. If this saved you time or sharpened how you think about even one of these studies, please subscribe, leave a rating, and share it with a colleague who would benefit. Disagree with me, especially about orforglipron, write to me, and we will do some feedback next week. Until next Saturday, this has been This Week in Diabetes and Endocrinology from Hormone Insight. This program is intended for healthcare professionals and is educational, not individual medical advice. Thanks for listening.